Bismillah ar-Rahman ar-Rahim. Specular Microscopy by Safaa Aboulhassan, MIOR. This is a specular reflection of the corneal endothelium. Function of the endothelium is formation of the collagen of the descent membrane, and more important, to keep the health and transparency of the cornea, which depends on its nutrition, on diffusion of nutrients through the aqueous. Detergence of the cornea depend on the fluid barrier function through the tight junctions between the cell and the metabolic pump function through the active transport. Normal corneal endothelium has normal shape, normal size, and normal cell density. What is a normal shape? The stability of the mosaic, at least 60% of the cells should be six-sided cells. Like this picture here, most of the cells are six-sided hexagonal cells, adjacent to each other, of average similar size and shape to maintain the function and the change in the shape named pleomorphism. Size, the normal size and rate of polymorphism, which aims at complete coverage of the corneal surface to maintain the barrier function and the active transport. Sloughed cells fall in the AC and replaced by adjacent cells, and the normal size is determined by coefficient of variation. Average size, when most of cells have the same size, then there is low coefficient of variation. This means a more stable cornea, while large coefficient of variation means that there is a wide variety of cell size. Change in cell size is called polymorphism. Cell density. Minimum number of cells to maintain the barrier function and the pump function is per millimeter square. Density does not determine the corneal stability. However, corneal insult decreases the cell density. Normally, the newborn have about 3,000 to 4,000 cells per millimeter square. The adult have between 2,500 cells per millimeter square to 3,000. Old age has 2,000 plus or minus 200 cells per millimeter square. This is pictures that shows different images of the corneal endothelium. The first one on the left is a one with almost symmetrical in size. There is no polymorphism, and almost symmetrical in shape. They are all hexagonal, six-sided, side by side, and there is no points that shows any deficiency or different size cells. In the second picture, the cells are getting bigger, then it shows polymorphism. Okay, they are still six-sided. There is no pleomorphism, or at least there is a very minimal pleomorphism. And here we find black dots that will be discussed later. In the third picture, we will see different size. The coefficient of variation of this image for sure will be high because most of the cells are not symmetrical in size. It shows polymorphism and pleomorphism. Not all of them are six-sided. Here there is a stage 3 normal GOTHI with normal cell count. Abnormal corneal endothelium shows pleomorphism in a rate that more than 50% of the cells are not, less than 50% of the cells are hexagonal. This is clinically significant pleomorphism, which increase in risk of atherogenic corneal decompensation. And elevation of the rate of polymorphism, this means that these cells are not properly functioning. Abnormal cell density, the decreased number of cells. Elevated rate of polymorphism is a first sign of endothelial disease, and it indicates physiological stress and overactive wound repair. It is determined by the coefficient of variation, as we discussed before. Coefficient of variation ranges normally from 0.2 to 0.3. Above 0.4, it's abnormal, and despite function may be normal, but it's susceptible for any surgery to be affected. Reduction in endothelial cell density, difference in density between both eyes more than 280 cells per millimeter square. Corneal endotheliopathy. Primary means congenital without pathological not induced, I mean. Secondary to ophthalmic or systemic pathology like increased intraocular pressure, uveitis, Fuchs uveitis, endothelial dystrophy, contact lens wear, intraocular surgery. Gothata is collagen deposition that forms nodularity in the desmet membrane, formed within the endothelial cells under stress, which secretes altered basement membrane material which accumulate in the cell. بمعنى ان احنا بيبقى فيه accumulation للكولاجين intracellular، وده هيبان في ان هي تبان في صورة nodules وتعمل nodularity. وhere it appears as a dark spot because it's not apparent in the specular reflection we do. So it's like an elevated point and not appearing on the plane image we take. Stages of Gothata, just for your general knowledge. Small dark structure in the center of the cell is stage 1. Nodule has the same size of the endothelial cell and surrounded by stretched cells is stage 2. Large Gothata including more than one cell, stage 3. Coalescent Gothata, cells in between are abnormal, stage 4. Progressive coalescence and visualization of the normal mosaic is impossible, is stage 5. Fuchs endothelial dystrophy is confluent Gothata with clinically significant corneal edema, progressive loss of endothelial cell function and structure, like this image. Age-related endotheliopathy, advanced age cause reduction in cell density and increase in polymegasism and increase plus or minus increase polymorphism. Iatrogenic endotheliopathy, surgical induced increased rate of endothelial cells, keeps going for 10 years post-surgery. Specular microscopy may show ongoing loss of the endothelial cell density over a short period. Contact lens induced cell loss is contact cause acute and chronic morphological changes. The rate increase in prolonged time of wear, decreased oxygen permeability, induced hypoxia, corneal swelling and deswelling repeated several times on putting on and taking off the contact lens, and the abnormal rate of polymegasism, polymorphism, and reduction of cell density. Stopping of contact lens wear does not induce immediate recovery of shape or function. Inflammatory induced endotheliopathy. It's a mononuclear inflammatory cells invade the endothelial cells tight junction and insert themselves between the endothelial cells and desmet membrane. This leads to cell loss floating in the AC, and specular will show well-demarcated, dark structure at the junction between cells, like the image below. Glaucoma-induced endotheliopathy, prolonged exposure to high IOP cause loss of cell density. One study claims that loss is due to abnormal aqueous outflow and oxygen concentration in the AC. Here is an image of a report. It shows the shooting date, the shooting time, the eye position, the corneal thickness, which is a first reflection of the endothelial function. We normally corneal thickness between 480 to 550. So 598 millimeter thickness is within range. Number of cells, 65 here is the number of cells that were studied. The minimum size here is 1 and the maximum size is kaza. Average is kaza. Size, standard deviation of size is 1.8. The coefficient of variation, which is the first thing to look at, is 39.9%, which is high. And the cell density, though, is 2100 with borderline, and the hexagonality is 50%. So it's a borderline image. Corneal endothelial cell morphology, we comment on the cell density, cell area, standard deviation, cell density, cells per millimeter square, polymegasism by the coefficient of variation, polymorphism, percentage of the six-sided cells. Thank you very much.